So this is my talk, shopping data and AI and disease forecasting and women's health. I'm Lizzie Dolan. I'm from Nottingham University and I'm a research fellow in health data science. This is, you can see on here, there's a picture, that's the building that I'm currently sat in. So I work at the NLab. And we're actually placed within the business school because what we do is we look at commercial data sets and we see whether we can do social good with them. And we look at all sorts. So I specialize in shopping data, but it could be drone data, finance data, mobile data. And I would say go and have a look on our website. And just at the start of this, I couldn't do this out without the wonderful team. There's a big team, so I can't name everybody, but I couldn't do all this without everybody there. So just shout out to the NLab. And I'll start. So why shopping data? So that's what I specialize in. So hopefully you'll be convinced of these points by the end of my talk, but it's because it captures self-care behaviours before diagnosis or during that kind of pathway to care. So that could be between appointments. Perhaps people aren't receiving the care they want, or they have they're misdiagnosis, so they go back and forth, or perhaps they're not telling the doctor everything. So it's so prior to diagnosis, but also during that kind of health care journey. This over-the-counter medications that people are buying can tell us a whole lot more about what's going on. And these data sets are really complementary to NHS records or pharmacy prescribed data. And they can reveal kind of early signals of symptoms of potential diseases, those hidden journeys. Maybe people haven't entered the healthcare system, and maybe we can capture inequalities in healthcare. And what I've found as well is I'm from a computer science background, and the NLab specializes in machine learning and AI and applying that to big data sets. So using this data with health has really enabled me to apply AI explainability tools that perhaps aren't used traditionally within the medical field, and that's been really, really interesting. So today I'm going to talk you through some studies that I've done, so on respiratory disease, ovarian cancer, and then this kind of shift to general women's health focus, looking at bacterial vaginosis. So this is my first, this is the first study I'm going to talk about. It's called, you can go and look at the paper. This has been published in Nature Communications, and it's called Assessing the Value of Integrating National Longitudinal Shopping Data into Respiratory Disease Forecasting Models. And essentially what that means is we're trying to predict weekly respiratory deaths 17 days in advance, across 314 local authorities in England. And the data we were looking at was from 2016 to 2020. And we created this model called PADRUS, which is predicting the amount of deaths from respiratory disease using sales. And we had 2 billion in-store sales. And you can see on the map across this distribution of stores across the country gave us a really, really good look across the whole of England. And we created a random forest model. And then we applied, because something that was very, very important to the NHS that we did this in partnership is not only that we showed that sales data could help predict respiratory disease, but that it added value on top of those traditional variables that they were already using. For example, weather, respiratory disease is quite seasonal, so quite easy to predict in a way, things like housing conditions. So they wanted us to show that shopping data added value beyond these traditional variable sets. So we used our AI explainability tool called Model Class Reliance. And I'm not going to go into that today of how that works, but I do have this very useful explainer video. So you can click on this link and go and watch the explainer video. And you can also go on the GitHub link and you can download the code, and we've got synthetic data on there so you can try out these methods. So how did we do with this model? Well, this is a very simple graph. If we look, we can see what this shows, the R squared of our model, and we want that to be as high as possible. The purple line is our sales model, so that's PADRAS with sales, and then the green line is our model without sales. And we can see that once we remove sales from the model, that the accuracy goes down a lot, and that is true within the test data. So the dark side of the graph is the training data, and then we tested it on unseen data, and that we can see how well the model is performing and how much better when we add sales data. So what made it work? Well, what we saw was cough medicine sales, 24 days in advance of that prediction, that were one of the key drivers of creating these accurate models. And what we also saw is those accuracy gains were the largest in volatile periods. So that was when the other features weren't performing as well. And our model class reliance, our AI explainability tool, showed that we couldn't actually get these predictions unless sales data was included in these models. So we couldn't swap it out for a different variable. So really what this showed was very robustly that adding shopping data made clearer and more robust alerts when the respiratory deaths were acting outside of those seasonal norms, where weather and things like static housing conditions that weren't changing in response were performing less well. And what we did with this study is then we took it onto COVID, which, as I'm sure we all know, because it's still all affecting us now, is much less predictable on a seasonal basis than respiratory disease in general. And again, we saw that the models were performing much better. And in fact, the mortality data that we had during COVID was much better because they were reporting it much more accurately and a much more regular basis, but still those models were performing much better when we added what people were buying over the counter. And again, you can go and look on these links to see more information about that. And now currently, because when we talk about respiratory disease in these models, we weren't actually looking at lung cancer. And now we've got additional current work where we're looking at adding sales data to NHS records to see if we can improve AI models that are used to see who should be brought in for lung cancer screening. So that's respiratory, but how do I get from respiratory to women's health? Well, something that I always hear is that shopping data is biased and it's unrepresentative. And I can't argue against that because that's true. For example, the analysis that you just saw is just from one retailer. So we're only capturing one audience, only looking at it from one lens. And even more so, this shopping data and some of the data sets that I work with are from 80% women. So really, really biased. But what I saw here wasn't necessarily just the limitation, but the opportunity. And when you get to look at this data, you see how many products and how much women are buying over the counter in response to symptoms and what we would call women's health problems. And really, really a kind of an untapped data resource. So the potential I've discovered so far is in ovarian cancer, bacterial vaginosis, and hopefully I'll be doing future work on general urogenital health, but focusing also on urinary tract infections. So my goal is to turn this perceived limitation and hopefully a breakthrough research for women. So this is the first study that I did in ovarian cancer, which, so need to give you a bit of background on ovarian cancer. I don't know how familiar everybody is with it, but unfortunately, because the symptoms of ovarian cancer can be very unspecific, for example, we've got them listed here and it's useful to know them. Bloating, changing in eating, so eating difficulties, abdominal pain or distension, change in toilet habits. They're quite unspecific, so often ovarian cancer doesn't get diagnosed till very late stage, and therefore the survival rates are not very good. But all these symptoms you can actually buy over-the-counter products for, as you can see here. And anecdotally, we're hearing that women were doing this, but there was what we wanted to do was get more concrete evidence, so we did this survey. And what this survey gave us was it confirmed that women were purchasing prior to their diagnosis. In fact, they were doing a series of different behaviours in response to their symptoms. But they were buying a lot of over-the-counter products, and they were also buying clothes as well. So what this gave us was a kind of feature shortlist for our models, or a variable shortlist. And then we also used this data to test the machine learning techniques we were hoping to use on actual shopping data we could get from women. But even outside of getting these two things, the list and the testing our techniques, we found really interesting results from this. So one of them was the women were 7 times more likely to have a duration of more than a year of health problems prior to a diagnosis of ovarian cancer if they were self-medicating based on the advice from a doctor. And the women in those situations who were self-medicating because a doctor believed their health problems were due to another condition from other than ovarian cancer were exhibiting distinct shopping behaviours. So then the second study that we're looking at ovarian cancer was working with clocks. So thank you for clocks for bringing me on as a partner for this study. And we were looking at actual shopping data through loyalty card data that women had given to this study. The clocks found that there was an association between the purchases of over-the-counter medications, pain relief, digestive medications. But what we were looking here was to see if those associations could move forward to predictions. So looking at it from a machine learning perspective and applying those learnings we had that we'd learned from the survey. So what were the results? Well, we saw that some patterns were suggesting early warning signs, and those predictions were better in models where we made sure that women were comparable in age and comparable in similar shopping habits. However, that brought our sample size down from around 200 to around 50 cases or 50 controls, depending on which time period we ran. We found that that we could improve models by adding shopping data, but this wasn't consistent. We ran 3 different time periods, and we saw out of 2 out of the time periods, they were successful in improving these predictions, which, given the sample size, is still really, I think, is still really positive, because we're such small sample size that we were seeing 2 out of 3 testings. And we could see that the products that were driving these predictions were antacids, so those kind of things for bloating or acid reflux, and vitamins, particularly effervescence for fatigue, and new clothes, which may reflect a change in body shape. When you have ovarian cancer, you can get distension of the stomach, but you might also lose weight at the same time. And I think probably that one, which we saw in the survey and has come out in the shopping data as well, needs further research to find out why that's happening. And very, very importantly, we were using data that was 160 days before these women had been diagnosed. So really showing the potential of using this type of data to push that, to push for earlier diagnosis and get those women the chances of survival increased. And this is more for kind of the technical ones out for you, or the epidemiologists. We're looking at area under the curve. And again, just simply put, the blue line is the model with the shopping data, and the green line is the model without the shopping data. And this is done on outer sample, and you can see that those improvements were good in 2 out of 3 data sets, but not in one of them. And that's because I really wanted to test these robustly. So we were looking at different time periods because shopping can be quite noisy. So why have I moved beyond ovarian cancer to wider women's health problems? And this is because of the feedback that we're getting from the public. I work very closely with the charity Overcome. This event that you can see on here is at We the Curious, worked with the University of Bristol. I've done a lot of public and patient involvement events. And when we talked about ovarian cancer, all these other women's health problems were coming out, especially around urogenital infections, urinary tract infections, menopause, perimenopause. And women were really keen that we use this data to investigate this further. And because it's about women, and we're effectively looking at what women are purchasing, their data, surveillance, it's really important for me to make sure we have this continued dialogue. So you can go and see from the blog there summarises what these public patient engagement events have come up with. You can go and see, I've done an interview with the World Ovarian Cancer Coalition to say why this is important. This is the video that I send out to get people's opinions, and we're continuing this public engagement with including a new partnership with Co-op. But once you started to investigate this, hear these women's voices about how they were shopping and how they felt often that their voice, they were being dismissed, then you look at the research, you can see that this comes out. I mean, urinary genital infections affect 400 million people worldwide. 50% of women will get a UTI in their lifetime. Bacterial vaginosis affects around a third of women. And they're not, although they're very common, they can really, really affect women, their quality of life. 800,000 UK hospital admissions in 5 years from UTIs, and there can be serious complications like infertility, chronic pain, antimicrobial resistance, which is a huge problem and that the government is facing and trying to tackle, with UTIs as one of the target conditions. And there isn't the surveillance around these diseases. For example, bacterial vaginosis is almost entirely untracked, and the tracking of UTIs is incomplete and fragmented. So we started with BV, and the reason for this is kind of serendipitously, I got contacted by Dr. Trish Hepburn from the VITA trial, which is a trial that was running at Nottingham University looking at using the efficacy of over-the-counter lactic acid gels for bacterial vaginosis compared to antibiotics. And actually, the trial was stopped early because antibiotics were so much more effective, and they had to take everybody off and get off everybody antibiotics. But these products are widely used, and what Trish asked me was, can we look and see what women are buying? We don't know what's going on outside the clinic. We don't know how many people are using these. We have no idea. So the research questions were, who's self-treating for BV? What are the patterns of use, recurrence, repurchase? Are there signs of burden or inequity in access to care? So we used 2.7 million customers. Out of those, we had 17,500 purchasers of BV who were purchasing over 35,000 treatments, and we were looking at a time frame of 10 years, 2005 to 2015. So this was historical data, and we created two models. One, to see who buys BV lactic acid products, and two, to see who was switching between products. And this was important in identifying need and treatment confusion. And we've got a quote there from one of the qualitative studies that was done on this. I was just basically at my own switch to try sort this problem out. I feel like I've tried everything. So what did we find from the first model? We got really good results. So we were looking at area under the curve of 0.79. And what we could see is those top predictors of BV purchases were higher spend on other items like intimate hygiene, thrush, cystitis remedies, and women had overall lower shopping frequency, but their spend was they had lower shopping frequency, but their spend overall was higher. So what we were looking at, maybe symptom confusion, this economic burden, and there was also inside some of the variables that were important were inequality signals. So there was small but consistent effects for index of multiple deprivation and stillbirth rate. The second model that we did was looking at predicting switching products, repurchasing the same product. This was a smaller section of women because these were women that would buy more than one product. We were looking around 6,000 events and around 2,500 women. And there was the models didn't perform as well as the who predict who would purchase BV, but they were still performing enough that we knew that there was patterns, and therefore we could use AI explainability tools. Here we're just using SHAP to see those variable importance and what was driving those models. And what we found is that switchers were repurchasing sooner, so they were buying more products in quicker succession. fewer prior repurchases, they were more likely to switch. They were actually in areas where there was higher I'm going to pronounce this wrong, metronidazole gel, which is an antibiotic gel, particularly for vaginal infections. Then the lower was the switching in the area. Again, there was higher basket spend and there were inequality signals, but the directions were less clear on these than in Model 1. So what these models essentially gave us were these kind of hypothesis generation of what were we looking at. So we tested some of those with just a simple Mann-Whitney U test, and what we saw is that women were switching from a cheaper BV product to a more expensive BV product, were more likely to live in areas with higher Black ethnic populations and areas with higher sexually transmitted infections. And this is actually reflected in the literature because BV is actually Black women are more susceptible to having BV, and BV actually increases your chances of STIs. So this is really early days, and as you can see, I've done quite a bit of research on this, but really and if you know of more people that are doing research in this area, please let me know. But the potential is clear, but there's a lot more work to be done. But hopefully I've showed you that shopping data really is an untapped lens on women's health. It can capture what maybe clinic is missing, and there's loads of signals that we could use maybe to see where we need to tackle inequalities, put those policies in place, provide those healthcare systems that maybe don't exist now. Yeah, so that's my presentation. Any questions?